All right, everyone. Well, welcome back to Kerrie Oakes from the Faculty of Health, who's presenting on Community Managed Herbal Medicine, results of a scoping review.
Thanks. Thank you, everybody, for being here. Anybody online as well, thank you very much. Thank you for the opportunity to present again. I'm actually now...
Just 2 seconds, sorry.
Taking 2 seconds. I'm now able to report on sort of the first phase of my data collection for my PhD, which is basically a scoping review. First of all, I would like to acknowledge the traditional custodians of the lands on which we meet, the lands on which I work. So in my case, the Yagara, Yinabara, Waka Waka, and there is a 4th group that has emerged in my area, which is west of Brisbane. So the area where I live and work is largely a meeting space. I'd like to acknowledge the custodians of that area, the elders. I would also like to acknowledge my PhD supervisory team, and I'd like to acknowledge my family, my friends, my partner Paul, who's supporting me here today, who's partly to blame on the PhD journey we're embarking on. Basically, very briefly, I'll give you an overview of the aims and research questions specifically for the scoping review part of my PhD, the search strategy, the results, and some of I'm now calling a preliminary analysis. I'm actually doing a more detailed analysis of the results of the scoping review and some early conclusions. So I am talking about a particular nuance of herbal medicine practice, which is where the community manages its herbal medicine practice, not the practitioner, not the healthcare system, but the community itself. And I am really looking at in my scoping review, to what extent has it been reported in the literature, and to what extent has herbal medicine healthcare been used in community health clinics? So basically, what is the evidence in the literature itself, and what does that literature tell us? 2 years, roughly, to do the search. I'm doing a scoping review, so unlike a systematic review, a very important part of this was also the grey literature. So not just academic peer-reviewed, but anything else that might be out there. Obviously, doing the normal review process, I followed the Joanna Briggs Institute methodology, so defining concepts, developing the search syntaxes, filing searches, refining the search terms and concepts and strategies, testing the searches again, doing some more refinement, and then conducting final searches. So that's why it took quite a while to do. I can tell you later, if you wish, the specific databases. I searched about, I think it was 8 academic databases, Google Scholar, Open Access Thesis Database, Cochrane, and a range of others. In terms of the database searches, I conducted social literature searches, I conducted social media searches, I've searched websites. I've done some snowballing by contacting professional herbal medicine associations globally and following through with contacts with herbalists globally, following various interesting little pathways. And basically we came up with 5,054 documents in the initial retrieval. 9 duplicates out of that, leaving us with 5,045 papers to do the initial title and abstract screening. We excluded 4,328. We then excluded another 578 got excluded full text. During the data extraction itself, we then excluded a further 13, and that was because one of the things I found was just defining the concepts became an interesting exercise in itself. Herbal medicine was relatively straightforward. Clinical practice was a little bit more complex. But community managed was the one that really we had to revisit, partly because in the initial inclusion, we included academic centres, so a clinic that was connected to an academic institution. So for example, here at Southern Cross University, we have a healthcare clinic. Herbal medicine is offered through, I think it's the Lismore campus and the Gold Coast campus shortly. So that initially would have fit into our criteria. But we're looking specifically for papers and documents and literature that talked about where the community itself, not just academics or practitioners, but general community, were included in making decisions about how their healthcare would be delivered. So we excluded 13 papers that specifically looked at academic clinics where there was no evidence of community involvement. And then there was an additional paper I excluded. So all up, we're doing an assessment on 126 documents. There are two stages to the analysis. The first one was just looking at the extent of the literature. What is the literature itself? Nothing predated 1970. Grey literature was 56%. So if I hadn't have done a scoping review, I would have missed 56% of papers, which just shows the importance of grey literature in some areas. 32.8% was based on websites. Study design was variable, but 64 studies didn't actually tell me what type of study it was. There were 3 quantitative studies. Most of the studies originated in the United States. Step 2, or the second phase of analysis, was to find out what did that literature actually tell me. So I looked again at 2 aspects. What did the literature tell me about organisations where herbal medicine was delivered in a clinical setting of some form that had community involvement in decision making? And then what things came from what those organisations' descriptions were. So first off, I found 92 unique organisations. So in 126 papers, 92 organisations were identified that had some form of characteristics that I could extract. 16 of those organisations were mentioned by multiple authors. One organisation, the Ithaca Free Clinic in New York, in the US, was mentioned by 5 authors. One of those was an academic peer-reviewed paper. The other 4 were through grey literature. And the types of characteristics that I identified and we extracted were the target group, so who were the people served by those clinics? What type of form was used clinically? Was it a practitioner and a client? Was there a broader community involvement? So was it basically primary healthcare? Was it comprehensive healthcare? Was it a mix of Western herbal medicine and traditional herbal medicine? What was the degree and type and nature of community involvement? So things like, were the community represented on governing boards? So there is a definition of a community health centre in the United States that demands that 51% of the governing board must be members of the community. So was that what people were involved through growing herbs? People were involved through running workshops. People were involved as volunteers, providing some form of support or service to the organisation. What type of funding was received? Sliding scale fees, fee-free, government funds, sponsorships, philanthropic trusts, fundraising through workshop and fee-for-service types of things. The type of organisation, so we found collectives, we found cooperatives, we found not-for-profits, we found incorporated associations, we found organisations that may not really be an organisation as such, it was more of a community. And one of the ones that was most interesting to me were the influences on establishment. Why was this thing established? What was the motivating factors? One of the interesting ones for this was the influence of the civil rights movement and social movements. So a lot of the free clinics or the clinics in the US, a lot of them talked about the influence of civil rights movements, the Black Panthers and civil rights movements of the 50s and 60s. In China, the influence of the Cultural Revolution in a very interesting model called the Barefoot Doctors. This is an example of the type of the table of the different types of characteristics. I apologise for this, it's very hard to get, but this is kind of where the clinics were located globally. So nothing in Africa that I could find, and that was largely because any of the literature that came from Africa was more a materia medica, an ethnobotanical study, these plants used for this condition, not how the healthcare itself was delivered. But pretty much everywhere. And then the thematic analysis. So this is a preliminary analysis that I did. I've extracted the data using spreadsheets and a data extraction table. I'm now going through using in vivo to do a more in-depth conceptual analysis, which is preparing me for the next phase of my PhD. But broadly speaking, the types of things that have come up that are common to these organisations, relationships, connection and context are important things. It's all about relationships. I suppose that kind of is a bit of a no-brainer. We're talking about people. Yeah. Healthcare is a political action. There is a political component to everything and to all of these organisations, whether it's a civil rights movement, whether it's about a response to some form of political decision, whether there's a political ideology. So, for example, the Barefoot Doctors in China, a very strong political, communal political ideology behind the creation of that model. Healthcare is a form of solidarity and justice. Healthcare is a human right. Healthcare is justice. Without healthcare justice, there is no justice. Are the types of things that were coming through. It was about knowledge sharing and preservation of knowledge, particularly for traditional communities. We're losing our traditional knowledge. We need to reclaim it. We need to reinvigorate it. We need to share it. How do we share that traditional knowledge? How do we bring up our young people to have that traditional knowledge? How do we share that traditional knowledge with cultures beyond our own? Transformation, we're transforming lives, we're transforming communities, we're transforming how our social structures are, we're transforming how our environmental structures are, so there's some transformative element. And of course, there are challenges. So challenges like funding. How do we afford to do this? How do we keep doing this? What types of privacy when the community's involved? How do we maintain client confidentiality, client privacy? How do we keep sustainable? How do we pass that knowledge on in a way that is respectful of the traditional knowledge owners and custodians? So I'm starting now to look at preparing for my next phase. So if I was to build a clinic today that was a community managed herbal medicine clinic, what does the literature tell me? It tells me that herbs are catalysts. It's not the herb itself, but it's what the herb does, what the herb prompts in people's thinking about how their healthcare is delivered or about how they want to receive their healthcare. Growing gardens is a part of and has become, so the herbs themselves are some form of active something in this. Health is broadly defined. It's not just your physical symptoms. It is a really holistic thing. It's important to be local. Local knowledge, local plant, local people, local decisions, permeating through all of this, and so attending to that local. Issues of colonisation and exclusion came up in almost every example. The impact of being colonised, of being excluded, and how is that considered? Policy environments were important. Where there was a degree of policy acceptance or policy framework that allowed this, it seemed to be no problem, very little problem. And there are operational things to consider. You do have to consider things like record keeping, where will you set up, what types of spaces are used, that sort of thing. And finally, the biggest thing that came up for me in all of this reading was that a community managed herbal healthcare was challenging my own definition of clinic. I started out thinking of a clinic as being a practitioner and a client in a fairly, you go to see your GP, that nature. But if I just looked at that model, there were very few. The clinic itself, and this is where our definition of clinic did encompass, there was a clinical encounter of some form. So there was that client-practitioner relationship, but the clinic itself could be much broader, and clinics occurred in buses, clinics occurred in gardens, clinics occurred in community halls, clinics occurred in a square room. But our notion of a clinic was I found that challenged. Thank you.
Well, thanks again, Kerrie, for that. You know my love for all things community driven. Do we have any questions for Kerrie? Shay?
I've got quite a big voice code all the time.
No,
For the tape.
it's all guys on YouTube.
Thank you, Kerrie. That was wonderful, and congratulations on your work. I can see that it's opening up something that's been diminished since there was the sweep of the Inquisition across Europe, and women and herbalists and herbal medicines and natural medicines were actually crushed, and Big Pharma took over. So amazing work that you're involved in and doing.
Thank you.
My question is, are you engaging with the local Indigenous herbal knowledge, or how are you considering your relationship with that, with the land that you're actually on?
Yeah.
I don't know whether much of it is alive in your area still, or, I mean, it's probably an extension
Yeah.
that I'm asking you about,
Yeah.
but that interested me as well.
Yeah, interestingly, so there is sort of more in Australia, there is a National Association of Aboriginal Community Controlled Healthcare Organisations. Interestingly, that didn't come up in my literature review. So it's like, I know that's there, but it didn't actually come through in the literature, which is interesting because it has been, that could be an issue of the search strategy itself. From a personal perspective, in terms of my own local area, it's interesting when we come to Indigenous knowledges and who has Indigenous knowledge, who's allowed to have Indigenous knowledge, the levels of knowledge. There's an increasing emerging of it. I'm actually also associated with the Indigenous Plants for Health Association, so I have some of that information and knowledge. As far as my PhD goes, there are some very interesting First Nations examples of this, particularly in Canada amongst the Inuit. There's one clinic that I would really love to go and visit and see. Ethically, there's some challenges with that, so I'm not sure whether I'll be able to or not. If not through the case study component, which is phase 2, the final component of my PhD is a Delphi consensus building approach, where hopefully I will be able to bring in some of the herbal knowledge keepers of various cultures to see if, particularly given that there was such a strong component in the scoping review, traditional cultures where herbal knowledge is still quite close to the everyday experience and practice of healthcare, were the ones that challenged the notion of a clinic. And yet there was community involvement much more strongly. Mexico is an example. Cuba was another example. So,
All right, so we might have time for one more question. Well, I've got one. So I'm just wondering what various understandings may be about a community managed herbal clinic. You know, on the one hand, it could be just something as simple as a community-based management committee employing clinical staff.
yes.
Or is there some nuance that I'm missing?
Well, this is kind of the question. This is kind of what drove me to start with, is what does it look like? So again, from my own personal example, I have started up a community cooperative that manages the healthcare clinic, the herbal healthcare clinic that I originally started. And that is a membership driven. They make those decisions. There's an example of alliances in the United States where, again, it's the broader community. They make those decisions. They manage the organisation, which includes employment. The Barefoot Doctor Scheme in China, which is no longer in existence, but basically the community or the commune chose who their practitioner would be, who would go and get trained to become a barefoot doctor. So I started the journey because I was originally thinking of community supported. We have this broad concept of community herbalism in which there's a whole lot of bits. But I was really looking at that. Where is the community involved in making decisions? Not just sitting on a board or just a volunteer, but actually making decisions.
Oh, look, well, thanks, Kerrie. That's fantastic.
Well done.
Yeah, and hope to have you back next year with reporting on it.
I've got lots of great stories of different types of clinics as well, which I'd love to share.
All right, thanks, Kerrie.
Yeah.